Welcome back, everyone. We are going to start with our last block of talks for the afternoon. Again, we are in for a treat. Dr. Pao joins us again, and he is going to cover a wide range of topics. And I think, as usual, please go ahead and put your questions in the question and answer, and he will tackle them as he is able to. And we will go from there. So, without further ado, I will turn it over to you.
Okay, great. Thanks. So we're going to start by talking about a bunch of common symptoms and how we sort them out and how we kind of answer questions around them. We're going to finish this piece with just a couple of really rare things just for grins, and then we'll move on to our next topic, which I believe is hyperlipidemia and hypertension. So the first case here, a 26-year-old woman presents with a 3-week history of cough. The cough began at the time of a URI with nasal congestion, sore throat. The nasal congestion and throat pain resolved 2 weeks ago, but a productive cough has persisted. Physical exam is unremarkable. At this point, what would you recommend? So, 3 weeks of cough, we see this all the time. Started with the URI, nasal congestion, sore throat, but now she's just coughing. Normal exam. Azithro for 5 days, Doxy for 7 days, amoxicillin for 7 days, chest x-ray, omeprazole 20 a day, or none of the above. Okay, we're just going to move on here because I gave too many choices and the right choice isn't an option for you. So the right answer here is none of the above. This is a patient which we see all the time, acute bronchitis, viral bronchitis is very likely, and these patients do not need to be treated, especially a young person with a normal physical exam. We don't need to get a chest x-ray, we don't need to treat them with a PPI, and we certainly don't need to give them antibiotics. Most acute bronchitis, probably 95%, is due to viral causes. Rarely chlamydia pneumoniae or mycoplasma can do it. And then, yes, pertussis is out there. It's still quite relatively rare. And the problem is by the time they come in to see us 2 or 3 weeks into it, antibiotics are not going to really help for the pertussis. So generally, we avoid antibiotics in this situation. We avoid working them up. And then we get into a whole bunch of things where we try to come up with some kind of treatment for them to humor them until it goes away. Half of these patients will say they have purulent sputum. They'll say they got funny colored sputum. So really doesn't matter when they say it's green or it's mauve or it's kind of a little bit blue tinged. None of that really matters. Um, the reason they get this is because they're sloughing tracheobronchial epithelium, and there's lots of inflammatory cells in this whole process as they slough the epithelium, so it will make funny colored mucus. Bottom line, if they have normal vital signs, absence of rales, and they don't have major risk factors, non-elderly patients with acute cough, we leave them alone. Treatment, boy, nothing really works. Antibiotics don't help for symptoms. If they have wheezing, maybe a beta agonist will help, but they generally don't decrease cough at 7 days if you blindly give them to everybody. And inhaled fluticasone may be beneficial in select patients. Those are probably patients with underlying undiagnosed asthma. And cough suppressants, including codeine, have little evidence of benefit. There really isn't any good evidence in well done studies that these things that patients try all the time really make much difference. Placebo does work. So patients will tell you that they take a cough suppressant with codeine and it works great because there's a 30 to 40% placebo rate for anything you give for cough. And this has been shown in a very nicely done study where they gave basically vitamin E placebo and it worked very well. 30, 35, 40% response compared to 10% when they just left the person in the room coughing. Sometimes patients will ask about honey, and there really aren't studies that are effective in adults. This is probably the most quoted pediatric study, which was quite good, and it showed that honey was at least as good, if not better, than dextromethorphan, and it was better than no treatment. So I still use honey in my adult patients, even though there is not a plethora of good studies in adults. A 37-year-old woman presents with 6-month history of cough. The cough is non-productive. She has tried numerous OTC cough suppressants without benefit. She's a non-smoker and no significant medical history. She has a normal physical exam, chest x-ray. I'll show you what is the next step in management. So here is the chest x-ray. So trial of an antihistamine decongestant, azithromycin, trial of omeprazole, a chest CT, or bronchoscopy. So what do we do here? Doesn't look like anybody's voting, and I don't know if there's a problem with the polls here.
No, I don't think you can see it until we share it. There we go.
Oh, here it is. Okay, now it's different. Okay, there we go. Great, thanks. Okay, so A is the right answer. A couple of you chose that, which is a trial of an antihistamine decongestant. A lot of people like giving PPIs, and I'll try to stress that's the least effective and least likely to work. If we're just going into everybody with no localizing factors with chronic cough, PPIs are probably the least useful. Useful in a few settings, but generally when a person has a chronic cough and everything else is normal, they don't give us symptoms, physical exams normal, chest x-rays normal, we're going to treat upper airway cough syndrome first, and that will be an antihistamine decongestant combination. Nasal steroids would be just as good or maybe even better choice here. So we always treat upper airway cough syndrome first if we don't have an answer. Chest x-ray here was entirely normal. So when we narrow the cause of chronic cough, we first want to make sure they're not on an ACE inhibitor, they're a non-smoker, and they have a normal chest x-ray. So these people have been coughing for 6 to 9 months. We get a chest x-ray. If it's unremarkable, they're not on an ACE, non-smoker. 99.4% of these patients then ended up having upper airway cough syndrome, asthma, or GERD. And we're going to show you that most of them have upper airway cough syndrome. In the lowest study, it was 41%, the highest 87%. Now, these numbers don't add up. They go over 100 in some of the series because some of these patients had more than one cause. But upper airway cough syndrome always wins in the United States, followed by asthma, followed by GERD. How do we diagnose upper airway cough syndrome? Well, the number one symptom is throat clearing. People who continually have to clear their throat often have this. On physical exam, you can see cobblestoning in the back of the throat. Sometimes you can see the back of the tongue is coated as well. So by history and physical exam, sometimes we can get clues when the patient is telling us, no, I don't have any postnasal drip. You can then push them on throat clearing. Here's a picture of cobblestoning. You can see really bad cobblestoning back here with chronic postnasal drip. As far as the best treatment, first generation sedating antihistamines work the best. Now, the current guidelines don't recommend using these in people over 65. Men can get acute prostate obstruction, urinary tract obstruction with the use of them as they get older. Older people can get confused on them. So, great option if you have a younger person with chronic cough, not so good in the geriatric population. You can use other antihistamines that don't work as well, things like cetirizine and loratadine. Adding a decongestant might help a little bit. It's the drying effect of the first generation that makes it so effective. And then nasal steroids, I think, are a good first line option, or adding it to the antihistamine. So we use a stepwise approach to our patients with chronic cough. First, if we find a clear cause, if you have somebody who tells you that they're having horrible heartburn and the cough started, sure, I would go ahead and start by treating reflux. But if there isn't a clear cause, then we start by treating upper airway cough syndrome. If that doesn't work and they have no other clear cause, then we'll try treating for asthma with albuterol and inhaled steroid. And then if that doesn't work, we'll treat for occult reflux disease with a PPI. The H2 blockers really don't work for chronic cough. They really need full acid suppression. And even then, it's only a 50-50 proposition that you're going to get efficacy. A 50-year-old man with 6 months of daily cough, normal chest x-ray, normal PFTs, and a normal methacholine challenge. You've done everything. You gave him diphenhydramine. That didn't work. Nasal steroids, that didn't work. Albuterol, let's say you threw in an inhaled steroid, that didn't work. You gave him some prednisone, that didn't work. He's used the steroid nasal spray, and he's used twice daily dosing of omeprazole. And every week he keeps sending you MyChart messages saying, I'm still coughing. Which treatment option might you consider next? Which of these would have the greatest efficacy? Famotidine, gabapentin, daily sinus irrigation with neti pot, ipratropium nasal spray, or colchicine? Okay, good. Gabapentin. Gabapentin's what we give to somebody who has everything, that we want to give them something they've never gotten. And there is data, and this study really had really had a major impact on sort of what do we do when we've tried all the things that should work for chronic cough. Randomized double-blind placebo-controlled study, 60 primary care patients with more than 8 weeks of cough, no COPD, asthma, tobacco, ACE inhibitor, recent URI, no response treatment for asthma, GERD, and PND. So they had all the right things done. Gabapentin 300 a day increased by 300 daily until cough suppressed, or 1,800 milligrams a day. Most patients got full dose by day 6. And the number needed to treat here was 3.58. So not terrible number needed to treat, but it didn't cure them. It was only dampened down while they took it. And you could certainly argue that, are we really happy with having a lot of people on 1,800 of gabapentin? But this is something to consider in your patients where nothing else works. Okay, we're going to now pivot and talk a little bit about another common symptom, headache. A 46-year-old man develops a severe headache this morning while working at his car dealership. He also has nausea and has had one episode of emesis. He has shoulder and neck stiffness that developed today. He's had no history of migraine headache or similar headaches, so he's really never had anything like this. And now he has nausea, thrown up once, shoulder and neck stiffness, and a very severe headache. What diagnostic test should be ordered? An MRI scan, a CT scan without contrast, a CT scan with contrast, lumbar puncture, or none of the above? Good. Most of you chose the CT scan without contrast. So given this age of this patient, the sudden onset of the symptoms, the neck discomfort, as well as the vomiting, all these things are worrisome for a subarachnoid hemorrhage. So a non-con scan is a great first test. You can just throw them right into the scanner. You don't need to worry about anything else. Get that information, and if it's a clean scan, then you can decide your next step. If it's a positive scan, then you can go ahead and find out where he's bleeding from, get your neurosurgeons involved. So CT scan without contrast in your high-risk patients where there's any possibility of a bleed. The acuity of onset here really suggests that. Here is this non-con CT of somebody with subarachnoid hemorrhage, and you can see how blood acts as its own contrast media here. This is data from 1983, first generation CT scanners. Even before we had better imaging, we were only missing 4% of patients who came in on the first day with subarachnoid hemorrhage with a non-con scan. Now that we have better, we're up to only missing about 1.5% to 2%. So it's a really good first test. If your pretest probability is sky high for subarachnoid hemorrhage, and they get a negative scan, you may then do a lumbar puncture, but this will obviate the need of lumbar puncture in 98% of your patients who have a subarachnoid hemorrhage. So we were taught that it's the worst headache of my life. We certainly think about that. I want you to think about it when somebody has a new headache or a different headache. If you have somebody with headache history and now they have a really excruciating headache that's different than any other one, we'll think about this. Average age in the US is 46. Most of these people also get neck pain. 20 to 25% of these people only present with neck pain. So put this on your differential diagnosis of acute severe neck pain that comes out of the blue. 20% have nausea or vomiting. And in one study, 50% of patients with warning bleeds were missed and then had catastrophic subarachnoid hemorrhages. So some of these patients do have a more minor bleed before they have a life-ending or a life-altering bleed. A 22-year-old woman presents her evaluation of headaches. She's had headaches for the last 6 months, occurring 4 to 5 times a month. The headaches are of great intensity, involving the right side of her head, with the maximum intensity of pain occurring behind her right eye. Symptoms worsen with exertion. Headaches last 3 to 6 hours, are sometimes associated with nausea, and on 2 occasions have been preceded by a scotoma in the right eye. Neurologic exam is unremarkable. So a young woman, headaches for the last 6 months, 4 to 5 times a month. Behind her right eye is the worst, and they get worse with exertion, 3 to 6 hours, and she's had a scotoma in the right eye twice. Normal neuro exam. What do you recommend? A CT scan without contrast, a CT with contrast, an MRI, an MRA, or no imaging? Okay, half of you got this one right, and this one I think is a very likely type of question to be asked on sort of uh, resource stewardship. And there are pretty good guidelines on not needing neuroimaging in a person who presents with classic migraines like this patient. The right age, this person's having headaches that last a while, 3 to 6 hours, very typical of migraines, behind the right eye, and even has a scotoma. So meets multiple migraine criteria, also worse with exertion. So we can give, with the normal neuro exam, we can give this patient a diagnosis of migraine and move on to treatment. This is a decree from the report of the Quality Standards Subcommittee of the American Academy of Neurology. In adult patients with recurrent headaches defined as migraine, no recent change in pattern, seizures, or focal neurologic signs or symptoms, routine use of neuroimaging is not warranted. Importantly, in the right epidemiology, that is a young, especially a young woman, new onset is not a reason to image. It says no recent change in pattern. They're looking more at people who have had established migraine, but onset of migraine in a young person, you don't need to neuroimage. Now, if you get an 80-year-old who looks like they got migraines, they've never had it before, that's totally different. That doesn't make any sense from epidemiology. A person that's, older than 45, that might be a case for neuroimaging because it falls so far out of the normal epidemiology for migraines. But young people don't need to image them if they have a normal neuro exam and meet migraine criteria. A 29-year-old woman is evaluated for headaches. She reports having headaches twice a month. She feels pain behind her right eye and frequent pain on her forehead. Her headaches often get better with 550 of naproxen. She has never had visual problems or nausea with her headaches. The headaches are worse with exercise. Once a month, the headache is bad enough to force her to leave work early. So, headaches twice a month, behind her right eye and on her forehead. Headaches get better with naproxen. Never had visual problems or nausea. Headaches are worse with exercise. Once a month, they're bad enough that she has to leave work early. What is the most likely type of headache? Migraine, cluster, muscle tension, or nitrate headache? So this is another very common variant of migraine. So the patient has a debilitating headache. Debilitating headache strongly suggests migraine. The patient has exertional headache. It's worse with exertion. It's behind the eye, so it's unilateral. And many migraines respond to NSAIDs. We always think of tension headaches being really responsive to NSAIDs, which they are, but many migraines respond to NSAIDs as well. So this is more migraine. So when we look at migraines, most people have a family history that somebody, either the parent or grandparent, has a significant family history of migraine. The problem with family history is some of the parents or grandparents were not correctly diagnosed with migraine. So asking about did they have sick headaches to put them in bed for a day at a time can sometimes let you make a diagnosis of family members many years later. Pulsating quality, very classic for migraines. Pulsatile, worse with activity, severities all over the map, but disabling. When a person has a disabling headache, that strongly suggests migraine. Motion sickness in childhood is very, very common in patients with migraine, and sometimes they have associated symptoms like nausea, photophobia, phonophobia, but they don't have to have that. So many migraine patients don't have nausea, they don't have photophobia or phonophobia. A 29-year-old woman presents her evaluation. She reports she has frequent headaches over the last 12 months that include pressure pain on her forehead, under her eyes, and over her cheeks. She usually has nasal congestion as well. She has not had any fevers or purulent nasal discharge. What is the most likely problem? So this person has, over the last 12 months, frequent headaches, pressure pain on the forehead, under her eyes, and over her cheeks, nasal congestion during these episodes, no fevers or purulent discharge. What does she likely have? Cluster headaches, migraine headaches, sinus headaches, or tension headaches? So this one's migraine again. Okay. So, first of all, should see sinus headaches are a myth. They really don't exist. People can get headaches with acute sinusitis. When they get a true severe acute bacterial sinusitis, people can feel a little full in that area. But that idea of recurrent headaches due to sinus disease, sinus headaches, extremely unlikely. What many people don't know, but has been out there for 20 years, so I think it's a fair question, is that there is a variant of migraine headaches that looks for all the world to involve the sinuses. This is a study of 3,000 patients screened who reported at least 6 headaches during the previous 6 months, self diagnosed or physician diagnosed with sinus headaches. 88% of these patients met International Headache Society criteria for migraine. And some interesting symptoms that we always think of as more sinus related, that 84% had sinus pressure, 82% had sinus pain, and 63% had nasal congestion. So what happens to these patients is if they get a migraine that's involving one of the branches of the trigeminal nerve, it will manifest itself in the sinuses. This is another study that reinforces that. 100 patients recruited who believed they had sinus headaches all got a detailed history and physical exam, given headache diagnosis based on International Headache Society criteria. Final diagnosis was the same types of numbers. In the mid 80s, if you total these all up, migraine with and without oral probable migraine, migraine with medication overuse, non classifiable, you're up in the 80s. 76% of the migraine patients had pain in the distribution of the second division of the trigeminal nerve. And most importantly, 62% experienced bilateral forehead and maxillary pain. We learned that migraines are unilateral. We're taught that from day one, and I think that's a good thing to think. But this variant, they can have bilateral symptoms, and that's why people don't think about it. So this is just a study that says, hey, if you do migraine-directed therapy, it works. And yes, triptans work for this. So patients did very well with triptans. 92% had response to migraine-directed therapy, and 82% of these patients had a response to triptans. We don't think of it as true sinus disease if they don't have a fever, purulent discharge, and especially if this comes and goes. This is something that comes 2 or 3 times a year, and we've all had these patients who say, I need antibiotics, I'm getting a sinus infection again. Every time you give me antibiotics, I get better within a couple of days. Well, it's because they have migraines, and migraines go away in a couple of days. Okay, it's late in the day. I know you all have fatigue, so now we're going to talk about fatigue. A 34-year-old female bank exec comes to see you for evaluation of fatigue. She reports she has had severe fatigue for the past 8 months. It began suddenly following a flu-like illness last winter. This illness was characterized by 10 days of high fever, myalgias, and tender adenopathy. Since then, she has had to cut back to 50% time at work, goes to bed at 7 p.m. every night, and wakes up unrested. Exercise makes her fatigue much worse. Outside tests include a normal CBC, SED rate, TSH, normal comprehensive metabolic panel, monospot test, and a negative HIV test. She has an unremarkable physical exam. It's totally normal. What would be the next step in evaluation? EBV serologies, mammogram, abdominal CT scan, blood cultures, or none of the above? Okay, great. None of the above. 73% of you chose that. And this patient's had a good and appropriate workup for fatigue. I think the CMP is appropriate, getting a CBC on the patient. They got HIV tested, make sure that's up to date. These are all appropriate things. They rarely ever turn up anything, but we don't need to jump into some of these other things like total body CT scans. And back in the 80s, EBV serologies were in vogue, but they really became absolutely worthless in the workup of fatigue. A 31-year-old construction worker reports that she feels tired all the time. She has trouble getting through the workday and worries that she may have a serious illness. Her fatigue has worsened since she was recently promoted to foreman, a job that requires longer work hours and a higher stress level. Which of the following symptoms are concerning for a physical rather than a psychological cause of her fatigue? Symptoms relieved by sleep, symptoms increase during periods of stress, symptoms better later in the day, symptoms that lasted for 10 months, or symptoms that began at the time her father died. So the key thing here is we're asking which of these are concerning for a physical rather than a psychological cause. Okay, so the right answer here is A. So individuals who have heart failure, individuals who have malignancy, their best time is after they've slept. If they've slept a full night, they might have 1 to 2 hours of some energy, and then they're exhausted and they need to take a nap or something to get a little bit more energy. Individuals who have anxiety, depression, other reasons that they have psychological causes for fatigue, their symptoms often get better later in the day. Once they get activated, they're better. The longer that the symptoms last, the higher the likelihood that it's not going to be a physical cause. So symptoms lasting 10 months really goes strongly against a physical cause. And then obviously symptoms that got worse at a time of stress would suggest a psychological cause and not a physical cause. So when you look at history to help you with your fatigue workup, psychological causes often follow a problem or conflict. The duration is chronic. It can kind of have good times and bad times during the day. Sleep does not affect these patients, that often they wake up dead tired in the morning. And they have this diurnal pattern where the morning is terrible, and then as they get going, things may improve a little bit. Whereas physical causes, the sicker they're getting with the physical problem, yes, the fatigue will get worse. It advances as the day goes on, it's much worse, and it's generally improved with sleep. You look at this type of thing, a duration of fatigue, and more than 4 months, you can see it flips. Less than 1 month, people that are tired, you often find a physical cause. They've had a recent viral illness, or they have pneumonia and they're getting over it. All those things make sense. We see this all the time. But once you get past 4 months, you flip to the majority of your patients having a psychological cause of fatigue. Very important when you work up fatigue is don't miss sleep apnea or a sleep disorder, because patients will tell you they're fatigued as opposed to being sleepy. And so what you want to ask is, do you nod off all the time? Is it that if you're not stimulated, are you falling asleep as opposed to just being tired? being fatigued where you just like, I don't have the energy to do that versus I keep falling asleep. And then obviously we want to do a screen for sleep apnea. We can do the stop bang is fine for that. Generally, we think about snoring. I think the very best in studies as far as high probability is witnessed apnea during sleep. So if a person has somebody sleeping with them who says they actually stop breathing, that has a well over 90% correlation with a positive sleep study. Daytime napping, falling asleep at inappropriate times. Any of you are asleep now, that's not an inappropriate time when somebody's lecturing at you. Then remember, and I think this is a very high probability of test question, we now look at sleep apnea being a driver for a number of people who have more refractory hypertension. And we really should be thinking about studying everybody with AFib for sleep apnea because our effectiveness of interventions such as ablations are affected on whether their sleep apnea is well treated. Certainly, people that are heavier have a higher risk, and individuals with higher neck sizes. So once we've done the workup for all these things and there's no physical cause, we can't really find any smoking gun, they don't have sleep apnea, then we look to say, could this person have what used to be called chronic fatigue syndrome? Now it's SEID. Look at reduction in ability of pre-illness levels for occupational, educational, social, personal activities for more than 6 months. The case I gave you is a person with this where they've had more than 6 months of excruciating fatigue that's really affected their life. Is it worse after exertion? Do they get malaise? Some of these patients will tell you for a day or two after exertion, their fatigue will be much worse. And is their sleep unrefreshing? In addition, one other of these two categories, cognitive impairment or orthostatic intolerance. So this is a fairly specific set of criteria. It's not just people that have been tired for a long time to meet true criteria for chronic fatigue syndrome. We talked about the workup, get the simple stuff, blood count, comprehensive metabolic panel, the SED rate, just to make sure we're not missing any inflammation, TSH, HIV, ECG is reasonable in your older patients. And then if they have muscle pain or weakness, get a CK. But, CBC and CMP is kind of the key parts of this workup. Don't order other exotic stuff, EBV serologies, other viral serologies. Get the EKG in your older patients and patients at risk for cardiac disease. Chest x-rays in people who have smoked is very reasonable, but we don't go crazy here because there's no evidence that it helps us with alternative diagnoses. We're going to move on and talk a little bit about acute hearing loss and what to do with that. A 57-year-old man calls on to report sudden hearing loss in his left ear. He comes into the clinic today and has a normal exam, except he can't hear out of his left ear, really. His ear canals are clear. Past medical history, hypertension, GERD, BPH. Meds are omeprazole, taurursine, hydrochlorothiazide, and spironolactone. What do you recommend for him? Stop his hydrochlorothiazide, stop his spironolactone, stop his taurursine, start acyclovir, or start prednisone. So he comes in today with acute hearing loss. Okay, so the right answer here is E, which is this person should get high dose steroids. You did the most important thing. You made sure he didn't have a cerumen impaction. We don't want to put people on steroids who have a cerumen impaction when they need their ear canals cleared out. But sudden sort of idiopathic hearing loss, acute hearing loss, they should be on prednisone. This is there isn't great data on this. This is 1980. There are certainly recommendations from ENT, and they have guidelines on this, which is treat with steroids. But this is probably the best study out there. 67 patients randomized to steroids or placebo within 10 days of onset of hearing loss. More patients treated with steroids recovered hearing, 62 versus 32%. Those with the most profound hearing loss didn't really benefit, and the greatest benefit was in the group with moderate hearing loss. Now, magnesium has been suggested, especially by our ENT colleagues to be added to this. And this is all I could find. I could only find one small study of 28 patients where they gave them magnesium in addition compared to steroids and placebo. And those with magnesium had improved hearing overall frequencies tested. Magnesium's not going to hurt them. I think it's reasonable to do, but it doesn't have an overwhelming evidence base. So what should you do? Trial of 10 days of therapy, and we give big doses of prednisone, 60 to 80 milligrams a day. Magnesium, why not? And those who don't improve, you send them to the ENT, and they may do intratympanic steroids. And I could find no good randomized trials for that, but that is the standard of care for that. Okay, we're going to move on and talk a little bit about leg discomfort, another common symptom. A 78-year-old man comes in for evaluation leg pain. He reports pain that occurs every day. It usually occurs when he is sitting down and also occurs at night when he is in bed. He describes it as a deep pain that makes it hard for him to get in a comfortable position. He doesn't feel the pain when he walks. It actually seems to improve if he walks. What is the most likely diagnosis? Vitamin D deficiency, peripheral vascular disease, spinal stenosis, restless leg syndrome, or varicose veins? Okay, perfect. We nailed the restless leg syndrome case here. So this is classic restless leg syndrome. The key thing is when he walks, it gets better, and then certainly it's occurring frequently at night. It could have been given to you as whenever he goes to a concert or a movie and he sits for a few hours, the exact same thing happens. So being seated for a prolonged period of time also brings this on. So it's very common with advancing age. Almost 20% of those over 80 have it. It's usually at rest, especially in bed. They get better with movement. And the bottom line, you might get a question that asks you, what lab do you want to check? And we want to know iron in all these patients because patients with iron deficiency can get restless leg syndrome as a symptom of their iron deficiency, and it can fully get better when you replete their iron. So iron is a very reasonable treatment if they have a low iron level. The magic number for what is a low iron level is a ferritin under 50. So in the restless leg guidelines, we treat with iron if they have a ferritin under 50. So treatments, dopaminergic agents, probably the most effective. Iron is very effective if they're iron deficient. Gabapentin and pregabalin have some positive effects and maybe the best first line agent, because if we use dopaminergic drugs, they work the best, but they're more likely to cause augmentation of restless leg syndrome if they're used chronically. There are some meds that can trigger restless leg syndrome: metoclopramide, neuroleptics, SSRIs, mirtazapine, tricyclics, and antihistamines all have been recognized as culprits of triggering restless leg syndrome. Okay, now moving on to a little bit of dizziness. When we see a dizzy patient, we need to put them into one of four buckets, and that will help a lot with the differential diagnosis. The first one is true vertigo. Is the room spinning or are you spinning around the room? Those people have vertigo. Pre-syncope, which is I feel like I'm about to pass out. I'm still aware. Maybe things are getting a little gray, but I'm awake and alert, and I'm about ready to pass out. This may or may not happen with standing up. We see a lot of people with orthostatic dizziness, and they'll give you that history that usually they have a rough idea what's happening, but not always. There are people with pre-syncope that move to syncope very, very quickly. Disequilibrium, a very common one. It's the person that tells you that they just don't feel right. And when you press them for the dizziness, they say, well, when I walk, I just feel my balance isn't right, but I also feel dizzy. And you say, are you spinning? No, it's not that. Are you going to pass out? No, I'm not going to pass out. And then they finally tell you the important thing. If I'm walking with somebody, I'm holding their hand, I have my arm on them, My grandson's walking with me and they're holding my arm. I don't feel the same way. But when I'm walking by myself, I feel it. Or if I'm holding onto the wall, I don't feel it as bad. That strongly suggests this what used to be called multiple sensory deficits or this disequilibrium. And the last case is everybody else. When they just can't tell you what's going on with them, they go, I feel lightheaded. And you say, well, are you spinning? No. Are you about to pass out? No. Do you feel disequilibrium? Do you feel kind of like a balance issue when you're walking? Like maybe if you held on to somebody's arm? No, that's not it. I just feel like I have air in my head. They give you some goofy description that they're bothered by it, but they can't really tell you anything specific. That has a very technical name, ill-defined lightheadedness, and that one is strongly associated with panic disorder and anxiety. So this disequilibrium, multiple sensory deficits, it occurs because people's vision isn't 100%. Maybe they have a little peripheral neuropathy. Maybe they have some orthopedic deformities in their knees and their hips. Their hearing isn't perfect. A little of this and a little of that adds up to, I don't feel steady. And these patients do great if they use a walker, if they use a cane, anything to get sensation through their hands helps them a lot. Ill-defined lightheadedness, panic disorder. Some of these patients, you can reproduce this by having them hyperventilate. And hyperventilation, there it is again. And so that's sort of my diagnostic test for these people where I think they have ill-defined lightheadedness. 32-year-old woman calls with symptoms of dizziness. She reports a feeling of spinning whenever she moves. Her only comfortable position is lying down. She's also had nausea and vomited once. These symptoms have been present for the last 12 hours. So she's just been lying in bed, trying to get up to go to the bathroom, and it's just spinning like crazy. She's crawling to the bathroom, vomited once, very miserable. No past medical history to speak of. She's not on any meds. Temperature 37.6, pulse is 100, blood pressure 100/60. TMs are clear bilaterally. She has an unremarkable neuroexam, except you notice she's very reluctant to move because she's very worried that you're going to make this a lot worse. And so you're very respectful of that. And her strength is fine bilaterally. There are no cranial nerve abnormalities. What is the most appropriate treatment for her? Reassurance, meclizine, diazepam, corticosteroids, or acyclovir? Okay, so the right thing here is corticosteroids. This person has probably viral labyrinthitis. This is persistent vertigo for 12 hours in a young person. So the likelihood of this being CNS ischemia, exceedingly unlikely, very likely to be a viral labyrinthitis. And this patient's had 12 hours of persistent symptoms. So reassurance, yes, someday you may get better. They're not going to be happy with you because they're vomiting and they feel awful. Meclizine maybe has mild benefit, but it's not going to help them as much as steroids will. So this patient should get high-dose corticosteroids. This was published in the New England Journal of Medicine about 20 years ago and has become kind of the hallmark study of this. A prospective randomized double-blind trial. Patients received placebo, methylprednisolone, valacyclovir, or valacyclovir and steroids within a couple of days of symptom onset. And then they actually measured vestibular function 3 days after the onset of symptoms and at 12 months. And mean improvements in vestibular function, 40% with placebo, 62% methylpred, 36% valacyclovir, 60% in the combination group, really suggesting the steroid was what was effective. We have to give big doses of steroids, and we give it for 22 days. So start with 80 and then we taper down. So this is not just a couple of days of steroids, at least if you're going to replicate the study. 56-year-old man presents for a routine clinic visit with symptoms of dizziness. He states episodes are particularly common at night when he rolls over in bed. They last for 15 to 30 seconds and then resolve. The sensation is that of the room spinning around them. So 56-year-old man presents a routine clinic visit with dizziness. Episodes get bad when he rolls over. They only last 15 to 30 seconds. What is the appropriate treatment? Epley maneuver, meclizine, diazepam, hydrochlorothiazide, or diphenhydramine? So the right answer here is the Epley maneuver. This is a person with BPPV, and accommodation exercises or the Epley maneuver is the very best thing that you can offer this patient. I will say I can't imagine meclizine is going to be the right answer on the ABIM exam. It's not, we give it maybe for motion sickness. Maybe if you have a true patient with motion sickness, that might be the right answer, but it's kind of a non-specific. If I think somebody's dizzy, throw it at them. And the American Geriatric Society hates it. So any geriatrician might try to nail you by getting you to order meclizine. So I'd really hesitate and look for a better option than meclizine when you're taking the exam. But the Epley maneuver can be remarkably beneficial for patients. Now, the good news with BPPV is patients generally grow out of it over time, but the Epley maneuver can speed that up. This is a study to look at natural history versus doing something like the Epley maneuver. 190 patients randomized to treatments or no treatment for BPPV. They are divided into posterior canal versus horizontal canal. 67% with posterior BPV got the Epley, 29 with horizontal got the Lempert, 60 with posterior BPV, and 34 with the horizontal got no treatment. Those are the natural history arm. At 1 week, 51% of untreated posterior BPV and 22% of treated posterior BPV had symptoms. So you see this remarkable improvement with doing the Epley maneuver. At 1 month, it was 20 versus 9%, 10%. So you see that the natural history is to get better over a month. But if you want to do it quick, have them do the Epley maneuver. And you can send them to physical therapy for that. You can give them instructions, give them a link to a YouTube video to see how they can try to do it at home, or you can do it for them. So the Epley maneuver is wonderful. 50% versus 17% for sham maneuver is another study. Drugs really don't work very well for this problem because the attacks are so short-lived. So just to sort out vertigo, vertical nystagmus suggests a central cause. So if you get a case and they tell you they have vertical nystagmus and they may be having a stroke or they have some other CNS process going on, if repeat Hallpike-Dix maneuver decreases the symptoms and fatigability is present, which suggests they have BPPV, and our patients who have central vertigo generally are older and they have other atherosclerosis, and it's very rare for them to have a brainstem stroke with only vertigo. They're usually going to have something else, dysarthria, diplopia, some kind of motor symptoms. Doesn't mean it never happens, but it's extremely rare to show up only with vertigo. So again, to reiterate, BPPV is brief vertigo, 15 to 30 seconds, maybe up to a minute, but not much longer than that, with positional change. Vestibular neuronitis, younger patient who gets sudden severe vertigo that lasts for hours to days. We didn't talk about Meniere's, but that's tinnitus. They often have some hearing loss in the background, have had earfulness for a while, then develop vertigo. And then older patients with atherosclerotic disease may have associated version. They should have associated symptoms in addition to vertigo. Okay, we're going to finish up by just talking about a little bit in difficult diagnoses, and then we're going to finish up. I'm going to show you my weirdest case I've ever seen. A 39-year-old man presents with symptoms of nausea and low-grade fevers. He's had increasing fatigue over the last 2 months. He's noticed a 10-pound weight loss in the same time period. He does not smoke. He drinks he drinks approximately 1 alcoholic beverage per day. He is sexually active with 1 female partner. His total lifetime sexual partners is 8. Physical exam I'll show you in a minute. So Now nausea and low-grade fevers, fatigue for 2 months, 10-pound weight loss, non-smoker, light drinker, sexually active with one woman partner, 8 lifetime sexual partners, physical exam abnormality. I'll show you. White count is 3-4 with 700 lymphocytes, 2,400 neutrophils. Hemoglobin is 13, hematocrit's 39, albumin 2.6. Transaminases are low, but alk phos is slightly high. Calcium is 10.3. Renal function and UA are normal. So, patient with a weight loss, low grade fevers, very tired, low lymphocyte count, low white blood cells. Transaminase is okay, alk phos a little bit high, calcium 10.3, albumin 2.6. Here's what we find on physical exam. We find this skin finding on the back. What test would you order next to most help you with the diagnosis? Which of these tests is most likely to be abnormal and helpful? Abdominal CT scan, chest x-ray, HIV test, RPR, or ANA? I told you this was difficult. Okay, so appropriate scatter for something this challenging. The right answer here is a chest x-ray in this patient with pulmonary and extrapulmonary sarcoidosis. And we'll go through why we think sarcoid makes sense. And chest x-ray certainly, if it's got bilateral hilar adenopathy and pulmonary nodules, we'd feel very comfortable with the diagnosis. So a chest x-ray is very, very helpful here. So what helped me? Well, first of all, this is something called Hutchinson's plaques that we see with sarcoid. These are flat lesions on the skin. This would be a very reasonable thing to biopsy to help you with the diagnosis. But this patient had lymphopenia. Okay, so they have lymphopenia. They also have hypercalcemia. They have a very low albumin because of the effect of having sarcoid for a while, and they're getting more systemic sarcoid here. And so they're getting malnourished. Their albumin goes down. Calcium is high if you correct for the albumin. They also have a high alk phos, and many sarcoid patients will have involvement in their liver and usually manifested by a high alkaline phosphatase. And then lymphopenia is very, very common during flares of sarcoid. So that could explain the lymphopenia. Some of you might have said, well, lymphopenia, that's got to be HIV disease. I didn't really give you any reasonable risk factors here that would make you jump right to HIV disease, especially with alternative things going on. So, what epidemiologic information would have more strongly suggested sarcoidosis in this case? If the patient was from Sweden, if the patient was from Canada, if the patient was from Southeast Asia, or if the patient was from Spain? So the right answer here is Sweden, which was the most common answer people had. Sweden is the sarcoid capital of the world with pretty stunning numbers compared to other places. Like the US, sarcoid is about 11 per 100,000 in Caucasians. It's a little bit higher in blacks at 35 per 100,000. But in Sweden, it's 64 per 100,000. We don't know what triggers sarcoid. Certainly, likely an antigen, and whether it's something people inhale, whether it's something they get infected with, we don't know. And we've been trying to figure that out for years. But it is very intriguing that Sweden, more than anywhere else, has lots of sarcoid. So I just threw that in. It's just kind of a fun fact. Which of the following clinical presentations would have the greatest specificity for sarcoid? So, which of these, if you see it, you can say that's sarcoid. Hypercalcemia, bilateral hilar in an asymptomatic individual, seventh nerve palsy, iritis, or erythema nodosum. Yeah, bilateral hilar adenopathy in an asymptomatic individual is a diagnosis of sarcoid. So if you get the chest X-ray on somebody that you're getting it for another reason, maybe they had an injury and you're just grabbing a chest X to see if they fractured ribs and you see bilateral hilar adenopathy and they're fine, they have sarcoid. Here's a great example of somebody with potato nodes, very, very, very big nodes that showed up and looks very, very scary, but the patient's asymptomatic, very likely to be sarcoid. Here again, more bilateral hilar adenopathy. And in an asymptomatic patient, that would be consistent with sarcoid. This is a hallmark study that was done at Virginia Mason back in the early 1970s. 85 patients with bilateral hilar adenopathy among 99 sarcoid, 500 bronchogenic lung cancer, 1,200 extrathoracic tumor, and 212 lymphoma patients. 11 had bilateral hilar adenopathy due to cancer. All were very symptomatic. 74 with hilar adenopathy had sarcoid. Every asymptomatic patient, 30 with bilateral hilar adenopathy, had sarcoid. Another way sarcoid can present is Lofgren syndrome, which is fever, erythema nodosum, arthralgias and arthritis, and bilateral hilar adenopathy. What I want you to remember for the pearl here is they often present with bilateral ankle arthritis. Hobble in with bilateral ankle arthritis. Very weird. People don't show up with just ankle arthritis unless they're having sarcoid. So if you see that, somebody with a fever and bilateral ankle arthritis, get a chest X-ray. Look for this entity. Erythema nodosum is on our differential of individuals, of differential of diseases that can be associated with sarcoid, and sarcoid is on the differential when somebody comes in with erythema nodosum. It's not anywhere near the top of the differential, but it can occur. This is lupus pernio, which is a disfiguring skin lesion frequently on the nose. We can sometimes see it on the hands as well, but it's central face, sometimes on the hands, and it can be very, very disfiguring. 29-year-old woman is referred to you because of an abnormal chest X-ray. She is in good health without symptoms at this time. 1 month earlier, she was a restrained passenger in a motor vehicle accident and sustained trauma to the chest wall. The X-ray was obtained to evaluate for chest wall fractures. Subsequently, she has a bronchoscopy with biopsy showing non-casein granulomas. PFTs are normal except for a minimal reduction in DLCO. Serum calcium is 9. Bronchial washings are negative for AFB. So we have a patient with an abnormal chest X-ray. I'm going to show you. I think I'm going to show you the X-ray. Here's her X-ray. Okay, so this was obtained when she got injured and it's abnormal. And so she had that workup, which had the bronchoscopy, which showed non-casein granulomas, negative for TB, minimal reduction in DLCO, but the PFTs are totally normal. What do you recommend for her? Treat her with prednisone, treat her with hydroxychloroquine, treat her with methotrexate, treat with interferon, or no treatment? Hey, right, no treatment. So sarcoid, remember, we treat symptoms. We don't treat and I will include hypercalcemia as a symptom. So if somebody's calcium's 14, we're going to treat them because we know they're going to get kidney stones. We know they're going to have other complications from their hypercalcemia. But as far as pulmonary sarcoid in the asymptomatic patient, especially reassuring PFTs, we're not going to change what happens with this patient by putting her on prednisone or any of the other drugs. So we're going to watch and wait with this patient. What labs are helpful in diagnosing and following sarcoid? I find lymphopenia is the most useful test. Very low lymphocyte counts, lack of improvement may be prognostically important. So when you see somebody who has sarcoid and their lymphocyte count is going down, it's a marker for more widespread disease because lymphocytes get sequestered in active granulomas. ACE levels, most people know about ACE levels. They're not all that helpful. Sensitivity is only 50 to 75%. Not clear on the prognosis. ALK-Phos correlates with liver involvement. And beware of patients who have a low 25 hydroxy vitamin D who have sarcoid. This is especially important in your patients who are heavily pigmented. In your black patients with sarcoid, they have very low vitamin D levels, often 25, but sarcoid patients who have active disease all have high 125 hydroxy vitamin D levels. That's why half of all sarcoid patients have increased calciuria. 10% have hypercalcemia, but 50% have too much calcium in the urine. And if we try to replete one of these patients without checking a 125 hydroxy vitamin D level, we are going to create multiple kidney stones. The most kidney stones I've ever seen in a patient at 45 individual kidney stones was a patient of mine who was put on high dose vitamin D because they had a low 25 hydroxy vitamin D level and had a 4 times the upper limit of normal 125 hydroxy vitamin D level. So beware of that. That would be a great test question. So when do we treat sarcoid hypercalcemia? We treat with steroids. Severe arthritis, we'll treat with steroids. Skin disease responds very well to steroids, except for lupus pernio, which often needs combination therapy. Iritis and uveitis, topical steroids. We need systemic steroids if it's severe. Pulmonary disease with symptoms, we start with steroids. Methotrexate is very effective for patients with pulmonary disease. And then cardiac CNS involvement, steroids, methotrexate, cyclosporin. We use a lot of infliximab in this group, and we use infliximab for any of these that are not responding to basic treatment. Hypercalcemia and skin disease can respond remarkably well to hydroxychloroquine. Here's our last case, the weirdest case I have ever seen. This is more a fun case. You will not be asked this. A 50-year-old man is seen acutely ill and with a marked change in color of his skin. So here is what the patient looks like. He's green. Here's what his urine looked like. Here's what his spun serum looked like. So what happened? Pseudomonal sepsis, envy, Hulk syndrome, or something else? Yeah, so this is something else. I mean, people are not going to turn green from pseudomonal sepsis. Green, if you have a pseudomonal wound, you can see green pigment there. But this was an odd situation where this was a person who'd had a transplant and then they'd had a CNS event and they were being tube fed and they developed an ulcer and they started to absorb tube feed dye that was blue green into their peritoneum, and then absorbing it, it got into their system. It was not metabolized and it turned them green and it turned their serum green and turned their urine green. This has actually been described. There are case series of this idea of like food coloring missing the stomach and getting into the body and turning people funny colors. Okay, well, we will stop there.